Hello everyone, welcome to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and once again I'm so grateful to have the chance to share with you this time and during this pandemic situation. And as I'm saying it all the time in all sessions, I have to say I'm so thankful and grateful to have great friends and great colleagues and leaders and teachers from around the world that are kind enough and accept the invitation for joining me and joining us every Friday with everyone around the world and share their experiences with us. And today I have a very, very dear friend, Dr. Hamid Ryan Kazemi from Washington, D.C. is here with me on Hot Seat. Hello, Hamid. Welcome to the show.
Hello, hello.
So happy to have you with us, my friend. Today we will have a kind of different program on Hot Seat because, you know, when we talk to successful people and leaders in our field of practice, usually a common question maybe for so many people, for undergraduate students, for postgraduate students, or even for practitioners doing their practice more than 10, 15, 20 years, is that how people manage everything together, especially successful people and leaders that we watch them over and over and we learn from them. And today, on the first part of the Hot Seat, I want to take this time and I want to ask Dr. Kazemi's suggestions and guidance for all of us because, a few minutes you will know, if you don't know already, that he's one of the most active persons I know in the field of oral maxillofacial surgery and implants, and not only in his practice, but also he shares. He's one of those people that really want to share what he knows, and I think and I believe it's one of the very key principles for successful people. And in the second half of the session, we will talk about the current concepts and the latest developments in treatment of periimplantitis and how we should manage those cases and how should be our decision making. So, Hamid, before we start, I would like to have your brief CV for our audience. I'm pretty sure you don't really need any introduction, but as a tradition, I would like to have this, and then we will start our hot seat session. Dr. Kazemi is a board-certified oral maxillofacial surgeon. He's the founder and CEO of Kazemi Oral Surgery and Dental Implants and maintains a full-time oral maxillofacial surgery practice in Maryland since 1997. Dr. Kazemi received his dental degree from the University of Pennsylvania School of Dental Medicine and then attended a one-year general practice residency at the Albert Einstein Medical Center, and subsequently completed his oral maxillofacial surgery training at the Washington Hospital Center in Washington, D.C. He is a member of American Academy of Oral Maxillofacial Surgeons, Academy of Osseointegration, Academy of Sports Dentistry, Entrepreneur Organization EO, Institute for Dental Implant Awareness, and a number of other professional dental organizations. He is also a contributor and presenter at Dental XP, one of the well-known educational websites, being full of great experts from around the world in different aspects of dentistry. And also, additionally, he's a consultant to DC United MLS soccer team and the US national soccer team for the care of their athletes. Dr. Kazemi lectures regularly on dental implants, bone grafting, and practice management. He regularly publishes podcasts, videos, blogs, electronic newsletters, and online articles. Dr. Kazemi's energetic and engaging multimedia presentation appeal to many clinicians, offering relevant, to the point, and practical information. Once again, dear Hamid, I'm so happy to have you with us, my friend. And I think today's hot seat is going to be not only very fun, but full of information for especially those people wanting to be a better practitioner and better teacher in their field. So as I was looking at your CV, you had your practice in University of Pennsylvania. When I joined Dental XP back in 2011, the person that I known that day and really helped me was Maurice Salama as one of the mentors of so many people and so many great things like you. All of them were at University of Pennsylvania, UPenn, and every when I look back at the history, not only we see so many great people coming from that university, but also even these days you see so many innovations and so many great moves even during the pandemic by this university. I'm pretty sure so many universities in the United States trying to do the same thing and they are doing it. But University of Pennsylvania is one of those that we really know it for greatness. And as the history of it says, people like Morton Amsterdam, the guy that so many people have lots of respect for him. So there is a lot happening in University of Pennsylvania. So I want to know, uh, how did you end up at UPenn? So what was the story behind it and how it started?
Yeah, I appreciate it. First of all, Omid, thank you for having me. I'm honored to be in the hot seat. I check my seat. It's quite hot. And thank you for the opportunity to chat. I love this format. I had a pleasure of getting to know you quite a bit through Dental XP and visiting Iran a few years ago to do a program. And you're just absolutely one of the most energetic, dynamic people in the field. And it's just a great pleasure to talk to you. So yeah, it's interesting. I devote a lot of my, career, what I've done and my successes, I suppose, back to how it all started. So I grew up in South Jersey, where I went to college, not too far from Philadelphia, where Penn is. And so my last year when I was applying for dental schools, it kind of came down to it was a decision between going to University of Pennsylvania, which I had gotten an acceptance letter from, and Georgetown Dental School, which I also had received acceptance. And so I'm kind of like going through, what should I do? Should I go to Georgetown? It's a great school. Should I go to Penn? And mind you, I had no idea what they are and what they stand for. And so anyway, long story, you would think that I would land in the dental schools. I did none of that. One day, I realized that the coats, the lab coats that they wore at Georgetown Dental School was this really ugly blue color, kind of like the shirt I'm wearing right now. And the lab coat that people wore at University of Pennsylvania was white. So I'm sitting there thinking, where should I go to school? And my decision came down to, could I see myself wearing this ugly blue coat for the next 4 years? I said, absolutely not. So my decision to go to Penn, in hindsight, what a great choice, was only because of a white coat. So go. Sometimes we make decisions based on completely ridiculous reasons, and if we're lucky, we make the right decision. And now that I look back, what we got exposed to, the faculty, the level of education, everything that the school stands for and still is, no idea at the time. Boy, I'm so happy that I stuck it out and I went there and I enjoyed the experience immensely. And looking back 25 years ago now, give or take, I really attribute part of my own growth and engagement in dentistry, what I had learned there. So anyway, that's kind of how it happened. And here we are.
It's very
And of
interesting.
course, meeting folks like Maurice Salama and these guys. Yeah.
Yeah, and so your undergrad program was at UPenn, right?
Yeah, so dental school was at Penn, and then I moved to Washington, D.C. for the residency for oral surgery. It's kind of where my mom lived. He was here and ended up finishing my program here for oral surgery, and then ended up staying. So, they say, be careful where you go for your residency program because chances are you end up staying there. That's what happened to me. I ended up staying in Washington, D.C. and been practicing since.
You know what's usually maybe interesting for, especially for undergraduate students, uh, when you were at the undergrad program, did you have any imagination of what will be your specialty, or did you have any plan for going through the specialty program? I mean, how did things
Right,
happen
right.
for you? And how did you
Yeah.
decided to choose the maxillofacial surgery, or I mean, the decision making on choosing your specialty? Can you tell us about it?
Right. It was really by kind of an accident. Um, my first, I remember the first month that I was at Penn. One day I was out and somebody said, "Hey, I'm going to the hospital to hang out in the oral surgery department." I'm like, "Oral surgery? What is that? Where are they at?" I had no idea. We just literally like the first month of doing orientation. So I kind of tagged along with this guy and went to the hospital and walked into the oral surgery department. I walked in and I think he was the chief resident or one of the residents who saw me. Is like, "Who are you?" I'm like, "Oh, I'm just the first year dental student, and I just took a walk just to see what's going on here." He's like, "Listen, we're really big to go to the OR. You want to go?" I'm like, "Okay, sure." So they literally dragged me. Next thing I know, 5 minutes later, I'm getting, a scrub on. They're showing me how to, wash my hands and get into the OR. And so I stood there as they did an orthodontic procedure. It was a Lafort one, osteotomy and mandible and moving things. For like the next 5 hours, I stood there with my mouth open and my eyes kind of glazed open, watching these guys doing what they do. And I remember I walked out that day and I was like, "Oh my God, what? That's unbelievable." It's like things that you just never could imagine that could be done. And I just went home and I was like, "Wow, that is intense." You just, right? And that was the day that I decided to do what I'm doing. I got totally inspired. I said, "That sounds really looks interesting. That's what I want to do." So pretty much for the next 4 years, I was pretty much focused on getting into an oral surgery program. And I think it was kind of a blessing because the competitive nature of the programs, the acceptance, I knew that I got to keep my act together and keep my grades and, make sure I don't slack too much.
Yeah.
And keep things afloat. So it was really kind of, an exposure and inspiration. And it was really, really helped to kind of form the path for me. So happy it happened.
Yeah, and it's very interesting. Hamid, I want to know because in different countries it can be different. How did you get involved with implant dentistry? Because usually, I know, for example, in Iran nowadays, maybe from 5, 10 years ago, universities have started to involving teaching implant dentistry. But also, when we are talking about maxillofacial surgery, their field of practice is so wide, and they have the field of trauma, they have the tumors, they have reconstructions, orthognathic, implant. So I want to know, how did you get also involved with implant dentistry, being an oral maxillofacial surgeon?
Yeah, yeah, yeah. The oral surgery programs, at least as of then, we're talking about, in late 80s and 90s, most of the oral surgery programs were not really that much engaged into implant dentistry per se. It did focus more on, orthodontic surgery and trauma and major reconstructive procedures. So in fact, in our program at the Washington Hospital Center, we had minimal exposure to implants. It was practically no foundation for any education in that regard. So when I graduated and finished and started practice, I felt a sort of attraction toward what I've learned in dentistry. I mean, oral maxillofacial surgery has a lot of major surgeries and medically related stuff, but I really enjoyed the dental part. And I knew that I want to be able to focus on the dental alveolar aspect of the practice. So it was really kind of a self-affirmation that this is really an area of interest. And I got more into it and not really educated myself through programs, through building on the foundation of what we had learned from surgical principles. We learned that, you know, we can easily do this. Now, back in the days, you know, there was a sort of a myth, maybe a label, maybe a stereotype that oral surgeons have rough hands and they are, you know, the macro surgeons and they get to do the huge big things, but when it comes to managing soft tissue and gingiva, not the right person to see. That kind of bothered me. It kind of got under my skin because it was like, wait a second, you know, granted I'm an oral surgeon, but I like to think that I have just as much respect for the gingiva as my other colleagues, and periodontists and other colleagues are well known to be more gentle with tissues. So it's kind of a little bit of a calling, a little bit of a challenge for me to develop the knowledge and the skills to be able to understand really the biology and the structure of tissue management and be able to do it as well as anyone should. Doesn't matter if you're an oral surgeon or a periodontist. I think it's just important that we just got to do the right approach and procedures. So I keep the same standards, whether you're a general dentist, periodontist, oral surgeon. It doesn't matter what background it is. What matters is that we're following biology, evidence-based dentistry, and doing procedures. So it was kind of a challenge and something that I really worked on and been enjoying the journeys ever since. And of course, you know, years later, we're still learning and we're still building and it never stops.
Exactly. And you know,
Yeah.
you are among the guys that, you know, because me personally, I'm a great fan of teaching and, you know, try to give away whatever I know to those people interested. And as one of your followers, I see that you are super active in teaching, in sharing, better say, and from every platform. When I see on Facebook, on Instagram, everywhere, when I see you, you are just giving people and try to. It's like because you don't need to do that, but you want to just share, you want to help, you want to educate, raise the bar. So I first want to know, when did you decided to go in the teaching path? And when did you start it? What was your first experience teaching and how did it happen? And what was it like that you decide to continue doing that?
Yeah, it's a good question. You know, I've been saying this for years, and I think anybody who teaches like yourself truly understands the power in teaching is really a selfish part of it is very selfish. And the selfish part of it comes from to learn more. And there's no better way to learn than to teach because look, you're getting up in front of people and you're going to say something and you're going to show a bunch of slides in your cases. You better know what you're talking about. You're in a position of, you know, you're exposed. And so, so it makes me go back and make sure I read up, make sure I understand, make sure I know my stuff. And I think that's the way that I've been able to teach myself and learn in the process. But I think the seed to, you know, to teach and kind of get into the more of the academics was seeded at Penn. So my year at Penn, we had a well-known presentation award. It was called the Morty Amsterdam Presentation Award. So I had just finished one of my big cases for my senior year. It was kind of a crown and sleeve full arch case, which kind of like, you know, the old days, nerf some of the teeth, do a gold coping and do a crown and sleeve. Anyway, so I documented this patient quite well. I've taken some good photos and my group leader had to say, listen, this is a very interesting case. You should prepare it to present it at the Morty Amsterdam Award at the presentation. I was like, really? It's like, yeah. we should do it. I said, boy, and you're like, you've never done presentations or speaking engagements. It's quite a nerve-wracking experience. Anyway, we put the material together, and on this one day, I'm getting up in front of the podium in the auditorium, and you can imagine this, that right in the front row seat, I see people like, Raymond Fonseca, Peter Quinn, Jay Silver, Dr. Van Arsdale, Morty Amsterdam, and just a slew of these big time people that they're sitting there and they're looking at me. Well, mind you say, I took a deep breath, and I don't think I took another breath for another 15 minutes, but I delivered and presented this case, which really was about a 15-minute presentation. And I, along with such a great moment of being in that position. And I remember that when I left, it was one of the most remarkably satisfying experiences that I had. It was kind of like delivery of this thing, and did it through it, and I probably skipped a few heartbeats in the process, but the feeling stayed. And kind of moving forward after, through oral programs and also the practice, it just kind of became part of the DNA of the practice. It was just part of the fabric. I just couldn't imagine that I could practice without documenting, without sharing, and both worlds just had to collide for me. And so I've been doing that ever since. I had an opportunity to do a lot of local programs. I ran into Maurice at one of the meetings back in the days when Dental XP was about to get started. And he said, hey, you got some material, come and join us. I said, yeah, I got a few things that I'm happy to do. So that kind of was the ignite into stepping into a little bit different arena, and really continuing on that experience. And here we are, where we are right now. This is my studio, which we actually opened a few months ago. So in fact, today we're in midst of recording some new programs that are done. So I do a lot of educational programs, not only from a professional standpoint, but also for patients, because part of my desire has always been how to educate patients to make better and more engaged decisions. So I'm actually working on a project right now with these weekly programs purely to connect with the end patients. So that's kind of like where we're at right now, and we keep going.
I have to say, I really wanted to ask this question because it's very interesting. You are in the practice for like 25, 30 years, and you've been through lots of teaching experiences, in lots of practices, and you've built up your empire, I can say. So you have everything, I mean, in access, and whatever you decide to do, it's possible now. But it's interesting that after all these years, we see that, your engine is working like the first year, and the excitement, the energy, and everything is there. So after 25 years, and when I told you at the beginning of our talk today, and I said, wow, look at that studio, so you're doing everything with lots of energy and as a perfectionist. So let us know, what is the secret behind it? If you wanna talk to our audience, especially those people interested or they wanna start, the beginners. And always I tell my students, when you love to do something and when you start to do something, it's important to continue doing it, not doing it for only 2 to 3 years and stop it, because that doesn't make any sense. So what is your secret behind it, and how do you see it now comparing it to before?
The secret. I'm happy to sell it to you. No, I'm kidding. I will share it with you freely. Look, at the end of the day, I think the secret is not quite a secret. It's one of the most obvious things that we all have heard. And I think those of us that are blessed to have this without working that hard for it are truly blessed. is it? I think there's this sense of excitement about what we do that is not work. I don't call it a job. I don't call it work. I tell my wife and kids all the time that I'm going out to play today. It's like me going to a playground. So my perception of what I do is not a job, it's not work, it's not to make money necessarily. But I really have always felt that I'm truly going out to play. It's like I'm out to an area that or a space that I have my toys, I have my friends, and I can kind of just play all day. And that's kind of cool. And by the way, you can get paid for it. I mean, what's more amazing? So I think throughout the years, you know, to maintain that level of energy and excitement is not easy either. Now, a few years back, and I'll tell you the story quite quickly. About 6 or 7 years when I was into my practice, you know, I opened a new practice and we were doing well and, you know, developed our referral base and the community recognition, so all these things, and worked hard 24 hours a day to build a practice and things were going well. And I remember one day I woke up and like, okay, we did that. And what's next? Where do we go from here? It felt like it was just like had lost that energy. Now it happened that around the same time, I went to an entrepreneurship conference. This is with dentistry. It was kind of a conference with, you know, CEOs and presidents of companies, and it was a global conference. And I remember one of the presenters was this Russian economist who had written a textbook, something like this thick of a textbook. And in his half an hour presentation, he was talking about the life cycles of companies. So I'm sitting there thinking, what is this? I have no idea. You know, I'm just a dentist. What do I know about this? What he said kind of stuck with me. He said that, look, the life cycle of every company and organization. What happens is you start a company, you start a, you know, an organization, and you put energy, you grow it, and you have this kind of this plateau of the curve that's shooting up, innovation, creation, product, and things are going great. You're making good money, and there's income, there's profits. And then at some point, typically about 6 to 7 years later, that plateau or that curve just kind of plateaus, it gets flat. And then what happens is that for most companies, if they kind of don't anticipate thatness, it starts to go down. So that curve of excitement all of a sudden diminishes and goes down into towards zero again, which basically he called death. And that's how a death of a company happened. So I'm sitting there listening to this with this curve on the screen of this plateau and, you know, and the curve down to death. And I couldn't help thinking to myself that, wait a second, I've been in practice for 6 or 7 years and I feel flat. I feel like I'm in that flat plateau. And I didn't like to see what's coming next, which is kind of a downward, you know, a spiral. He said that, look, in order to avoid a plateau and going and dying, what companies have to do is to re-innovate. They have to rethink things. They have to get a new product, a new thinking, a new way to do things. So as soon as you hit that plateau, you have a new reason to live. So all of a sudden that curve shoots up again, and you like for the next 6, 7 years, you're on an exciting journey to recreating your product, services, and profits, and whatever it is that follows. And then 6 or 7 years later again, it's going to happen. So, you know, they call it the 7-year itch. Maybe that's why they call it that, because I think not only professionally, but also personally, we might go through this flat curve. And so I listened to that, and I came back, you know, back to Washington to practice. And I said, I'm in a flat zone and I need to re-innovate. I need to do something to wake up again, to get that energy back. So what I did was got into, you know, creating a website and doing some online material. And I was kind of like excited just to kind of learn how to do videos and how to do a podcast. And then, really kind of woke me up and excited me about what I was doing. Mind you, about 6 years later, I hit the curve again, or I kind of felt it was coming. So at that point, we opened our implant center, and then we kind of got into the digital world and digital workflow. And I felt like I was, a little boy in a candy store again. That excitement was back. And then the third phase of that, because again, 24 years in practice, and about a couple of years ago, I felt like, what's next? What am I doing again? And that's what sort of propagated me into opening this. So this is really kind of a continuation of the same experience of how can we reinvent ourselves? How can we do what we love and just kind of add a level of spice to it? And so that's my secret. My secret is I'm always thinking of the next thing within the context of what I'm doing. I'm not doing anything different. I'm still doing wisdom teeth, implants, bone grafting, tissue, whatever. But the way we do it, the way we express it, the way we interact with patients is completely different. And that's kind of what keeps me happy, I guess I should say,
Great.
and hopefully it will keep it going for a long time.
I
think my secret is that it just keep it going.
And also because you love what you do, that's why you can keep it up and go to the next level. And
yeah, no question.
You run your practice solely, and as I know, you're a sport guy, you're a family guy, and you teach, you write, you record, you do your practice, so many things, but you have to keep the balance. So how do you do it? How do you, because some people think that, well, I was in the university from, 7 or 8 a.m. to 2, and then I go to my private practice, and when I come home, I'm tired, I just want to watch TV or sleep, and the next day is the same. But sometimes you need to take care of yourself, you need to do the exercise, you need to have your private time, you need to have your time with the family, also doing what you love in your practice with high energy. So how do you manage that? And what's your recommendation for people want to be like you?
Yeah. No, look. I think. Look, there's no easy way around it. It's difficult and challenging. I'm a solo practitioner, by the way. So I run the practice. I have a team of 7, 8 people in the office, and we have our educational thing that we do with the facial dental forum, and of course the studio. So there's a lot going on. Now, luckily, my wife is a wellness coach. So I've learned a lot from her. And one of the things I've learned, both through my experiences and also what I've listened to her, is that first of all, the whole idea of work-life balance, it may be a myth. I don't think there's ever such a thing as a balance. I think there is an imbalance. And I think it's almost, maybe foolish to think that we can achieve balance ever in life in that sense. There are times that I am spending crazy time on the work side and maybe presenting, traveling, and working on projects. And then I find myself other times completely devoted and committed to personal time, family time, kid time, and having fun. And of course, the 24 hours, they all run together, right? So in a way, it may be a myth in some sense, but I think the way that it's making it work for me is, number one, having a great team at the office. So there's no way that we can do this alone. Been fortunate to have a great team of people that work with me. Very fun to practice while I do my thing. And also, I think the discipline of eating well, the discipline of sleeping well, discipline of exercise, it's not an option. It's a must. It's just as important as everything else. So I think for me is really kind of sticking to those routines. whether it's to get my run, my bicycling, and triathlon stuff, and really doing that to make sure I don't compromise that, spending time with the family, traveling, having fun, spending time with friends. I think all those things kind of feed into the professional 150% focus and attention on what I'm doing here, and there's not a dull moment. So I don't know. I think it's a combination of just team, having good people and having that discipline to keep health, and they kind of run together. It's certainly not easy and challenging, but it just there's no other option. We have to stick to it
Yeah, I like that.
because the alternative is not fun.
Big, no, but really, I liked it when you say that it's not possible to make a balance because we have to play with it, and we should see in what side we can be more satisfied. But definitely, we should not forget to have the other side because we should not go through the tunnel, and we should have everything, every possibility that we have to enjoy every second of our life. And Hamid, I just now wanna before I go to my last question, other than the scientific part, I wanna just now because go to a little path in our field of practice, because I know that you've been involved in so many things in implant dentistry and maxillofacial surgery, and one of the things that I know that you are really expert in it is treating periimplantitis and difficult cases that also I had a chance to be a host at the first International Symposium of Complications in Implant Dentistry in Tehran. And you really showed us great classifications, how we can decide. So now that we are about 3 to 4 years, passing that event, and so many things happens around the world in the protocols of treating our patients. I want to know, first of all, do you think that we can have a routine approach for treating periimplantitis cases? Do you think it's comparable to periodontal cases in 2020? And is there any valid protocol for treating those patients or not?
Yeah, look, the conference that you hosted in Iran was really, I think, right on. It was such an important topic. And through the past number of years, we all have seen the increased incidences of periimplantitis, the number one challenge, the number one issue that comes up. And I think that we're starting to see the outcome of therapies done 5, 10, 15 years ago, where people are coming back, and some of them with periimplantitis. I've been following some of my own patients for the past 20 years, and I see some of them coming back for different type of treatments. That gives me an opportunity to assess what I did 5, 10, 15 years ago. And it's interesting that I see that some are completely stable, well, and just right on. And I see that some of the ones are showing and exhibiting signs of periimplantitis and issues. And so a few years ago, I tried to get a better understanding of this. I was starting to treat a lot of patients that were finding us for various kind of complications. Periimplantitis was probably the number one. Brought me to share some of those thoughts in the patient ebook that I wrote, just as a way to educate patients on what periimplantitis is, what we know about it, what we can do about it. I put it up on our website for a free download. Again, it's just kind of like a way to educate. And what I can probably tell you is that what I've learned is probably two main points. Number one, what I realize is that most of the cases that I've been involved in, that I've seen not only from others coming in and also my own patients with periimplantitis, 90% of them could have been avoided and prevented. And I'll tell you why, because one can diagnose and understand why it happened. So majority of the cases I think are preventable. And that really led me to understanding, well, if it can be prevented, not in every patient, but in most patients, What do we need to do that? What are the critical elements to address it? I think treatment of periimplantitis is quite still challenging. We're still trying things that are being published and done, whether it's GBR, whether it's surface therapy, whether it's laser therapy. And I can tell you in 2020, soon to be 2021, we still don't have a very good prognosis of treatment when it comes to managing periimplantitis, specifically the ones that are more advanced,
Yeah.
which leads me to think the focus for us has got to be prevention. How do we prevent it? The prevention to me is multifactorial. Look, that's a big truck of of principles and concepts. But here's how we can simplify it. I think the prevention comes from the following. Number one, we got a bone. Without bone, we get exposed threads. It sets up disaster for a periimplantitis. We got to have thick, soft tissue. We've seen this presented by a number of clinicians that thick, soft tissue will protect us. We got to put that implant perfectly in the right position with sufficient bone. How do we do that? Digital workflow. Every case you go through digital workflow, digital planning, surgical guide fabrication, and that whole workflow. Next is patient education. I think that's a part that has a huge factor, enabling and empowering our patients to take care of themselves at home, how to maintain it, how to manage it. And I think every patient is different. The hygiene protocol is going to be different for every patient. We cannot give the same recipe of go floss and brush twice a day to every patient that goes out the door. It just doesn't work. Every site is different. Every implant level is different. Every contour is different. So I think patients need to have a very much a customized hygiene protocol for what works for them in their hands, what's effective, what kind of tool to use, and help them to be more successful. And also professional maintenance every 3 to 4 months. I always say, the old, every 6 month follow-up for hygiene should be completely thrown out of the door. That's only for people who have perfectly healthy teeth and have no restorations, no crowns, no root canals, and wonderful. Yeah, every 6 months you're good. Otherwise, the rest of us with dental work, treatments, implants, every 3 to 4 months. That's what I tell my patients. And I think lastly, the protocol for implant care also has to change. I had the opportunity of working with an implant care practitioner who specializes in implant care. I learned a lot about the different protocols that hygienists can use and different techniques and modalities to maintain and prevent periimplantitis. Kind of changing that topic to the treatments. What do we do? Early implantitis. Yes, surface treatment, detoxification, degranulation, attempting criteria, the size of the defect, both from the width of the defect as well as its length need to be considered. And we have to have a candid conversation with the patient in terms of the prognosis, to try these procedures. But there's promises because we know that it's very difficult to have long-term success from some of these cases. Certainly, I've had successful outcomes managing periimplantitis, regenerating bone around lost defects and regenerating tissue. But it's not something that predictably we can tell people can be done all the time. So as long as we, I think communicate that effectively and the limitations, it's certainly okay to try. At the same time, we have to be better diagnosticians and provide a better prognosis given the situation. So we have to face that hopeless situations are hopeless situations. And maybe the better service would be explantation, site development, and redo the case 6 months down the line with a new implant, rather than trying to spend the time and effort and money trying to save an ailing and a failing implant. So I think we need to know where to stop and when not to be too hopeful.
I mean, that was the point, because you started from prevention, and I totally agree with it. But when the periimplantitis happens, I think, simply say that we have two scenarios. The patient comes regularly and we see with cleaning, maybe non-surgical treatment, or maybe with a little short surgical intervention, we can control the case, and the follow-up, everything is stable. But in some cases, it's progressive. And at least if it's not progressive, but signs or symptoms are there. So gingiva always is swollen, or you have some bleedings, or when you put pressure, you have a little suppuration. So do you think the most predictable approach going to be explant that dental implant and redo the case, instead of waiting and try to save everything, but knowing that you will lose more bone and more tissue, and doing it again in years later going to be much more difficult? Do you think explanting in earlier period of time is a wiser choice, or no?
Yeah, look, I mean, I think the primary challenge is how do we get rid of the biofilm? So we have implants that has exposure, inflammation, peri-implant mucositis or peri-implantitis with some level of bone. And the question is, there's no chance in regeneration if we can't get the biofilm removed. And the question is, how do you remove the biofilm? Yeah. Chemically, mechanically, question there. Laser, haven't seen long-term studies, may be effective, we just don't know yet. There's certainly the air powder modalities of being able to blast the surface of the implant to try to remove the biofilm. Maybe it works. Again, we don't have any long-term studies in terms of its efficacy. So I think in terms of the option moving forward, if the site is significant, if it's minor, maybe we can manage. But if it's significant, I think the explantation and site development is a more predictable way to go. Now, in the old days, if you recall, when we had to remove implants, it was the ugliest, most traumatic, my least favorite type of procedure. We really had to take, a trough burr and cut bone and create a bigger defect. It was ugly, it was bad, and I hated doing it. But now, as you know, with our explantation kits and tools, removal of an implant is not a very difficult task. It can be done less than 5 minutes in most cases with no bone removal, practically no incision. And so that part of the equation is no longer a factor. So if I can tell to a patient that we can atraumatically get that implant out and do a very predictable GBR procedure in those cases and redevelop the site, and then have the opportunity to not make the same mistakes again. Because it kind of takes me back to, why did it happen to begin with? Not enough bone, not enough gum tissue, the implant was too angled, coming on the buccal. That's going to develop periimplantitis every time. Yeah. So now we can learn from that and saying, okay, let's go ahead and make sure we don't make those same mistakes and stick to developing the foundation, the tissue, the right implant position, and restoration, and all the things that we know works in prevention. And I think that most patients like that because it's more definitive and more predictable. But ultimately, again, it's really a conversation that needs to happen. But yeah, I'm more and more maybe inclined in majority of the cases to offer this as a more definitive option. Now, if somebody wants to try it and they want to hang in there, it can be done, but no promises. I may tell them, look, 20 to 50% at best in terms of prognosis and it working. If they're willing to take that chance, I suppose they can, but we just got to be honest with them and ourselves in terms of what's possible.
Great point. And I wanna add a fun part to my questions now as the last part of the scientific questions.
All right, fun part.
I want to do it.
My favorite.
I want to go with like a yes or no. Yes and no answers. Okay. So, in your experience, in your practice, daily practice, if I want to ask you the questions regarding how do you decide to clean the contaminated implant surface. I want to have, I will give you some options. So let me, if it's yes for you or if it's no in your experience in 2020. So let's go for it.
Okay.
Titanium brushes.
Okay.
Titanium brushes.
Titanium brushes, boy, so now you get into a gray zone maybe. So with titanium brushes, maybe we can remove plaque, hard calculus, and buildup, but it doesn't do anything about the biofilm.
So
the answer is no by itself.
No.
In itself is a no.
What about lasers?
So lasers now maybe start to offer us a way to remove the biofilm. So maybe in combination with a mechanical debridement, whether it be the brush, or whether it be the air powder way to remove hard debris and clean the surface, perhaps. Now, I don't have any experience with it, so I will tell you that much. But from what I've seen in the literature, there is some reports of early success, but we don't know how these cases look in 5 years, in 10 years. Is it gonna stay? Is it gonna persist? What I tell patients is that we don't know. Can we try it? Yes, but no guarantees. So I think the answer to that is by itself, again, not an effective modality. Mm-hmm. Combined with other techniques, maybe have a chance in some defects. I know it's tough to say yes and no. This is a hard game.
It's almost no. What about air powders like jets?
Yeah, so air powder, we actually using that. We added that to our management strategies. So when I'm doing cases that require surgical interventions, we're using that as a way to remove the biofilm as well as any hard buildup, calculus things. I have a few cases that are about a year to year and a half in their healing progress, not long enough to know where they're at. So far, it looks promising. These cases are not getting worse. The question of whether or not the bone regeneration that we attempted is going to stay or not, I'm not quite sold on that. But what we have observed is healthier tissue, less inflammation, and more stability. And I think in some patients, depending on their age, depending on the location of the implant, maybe we can hold on to these implants, even though they're not ideal, but they're as long as they're not getting worse. So I think the answer is I'm excited about the air powder as a modality in combination with surgical techniques.
But
certainly in terms of prevention, it's wonderful.
Yeah, but do you have any concern using Profijets because they have pressure of air when you're treating periimplantitis cases? Do you have any concern for emphysema that happens during using the Profijets with the pressure of the air that is pushing to the bone?
We have not experienced it at all. So no personal experience. Have not seen it happen with any cases.
And what about the water jets? Water pressure.
Water jets. In terms of the same modality from the air powder?
During the surgical interventions for cleaning the implant surface.
Are you talking about purely a water jet to clean?
So for cleaning, but the surgeon used for, with high or low pressure for cleaning the implant surface.
No experience. Couldn't tell you. The answer is that I don't know.
So that
purely for cleaning of the surface, the protocol that we followed in some of these cases is surface debridement using the ultrasonic cleaner, which is really a kind of a part of the air powder machine that we have. And then you removing the biofilm and just irrigating it as thoroughly as possible. I even go through, placement of some antibiotic infused in gel foam on top of it. I don't know if it works or not, but at least to kill some of the germs and bacteria that is in the tissue there and leave it there. So this kind of goes back to, you know, the old studies and protocol by Murphy, who had done the site treatment with antibiotics. And so we're combining everything to hope that we can maybe get some results.
So the reason I ask this, because nowadays one of the concerns that so many people have is about the changes that may happen through the surface of the titanium using different instruments like ultrasonics, like titanium brushes, and etc. And one of the interesting studies that I read, and I had a chance to also talk to the author, Georgios Kotsakis. I think you know him from University of San Antonio, Texas. So they showed that the least changes that happens in the surface of the titanium after treating periimplantitis was with the water jets. The minimum amount of changes on the surface. So that was why I asked to see if you also had experience with it or not,
Right.
because that was the reason. So
Yeah, I think it, again, by itself, it may be limiting because of the infusion of the biofilm and the toxins in the substance of the titanium rough surface itself. The question is, how does that get out? So I don't think we know, but certainly maybe a combination of mechanical and chemical treatment, mechanical therapy in combination. And the long-term sort of certainly prognosis is unknown in those cases.
yeah,
But I think we will learn more. Yeah.
yeah, great. That was a great conversation with you, my friend. But my final point is this: for Hamid Ryan Kazemi, what is next? Because you always come with very great ideas. So what's next?
Yeah. So right now we're excited about a couple of projects that I'm working on. One project is we just started. We've had a little bit more time on this, but we're developing some exciting programs for patient education. I have a new weekly podcast that I launched called Hints and Tips in Dentistry. It's out everywhere. And the message is to help patients understand little things, little bite size of information, so they can hopefully make better decisions. The other thing that we're working on that's very excited is, and this goes along with the Smile Studio that we opened. One of the missing links for me has been how we take the surgical discipline and how do we kind of fill in the gap, that bridge to the restorative aspect. And we all understand that the importance of what we do as surgeons on what happens on the restorative front. And we cannot argue the fact that the restorative treatment or the restorative aspect treatment kind of is set with the foundation that we provide as surgeons. So we have to do more than just placing the implant and making bone. We have to kind of like see the patient through this transition between surgical world and the restorative. So part of this project has been to develop our Smile Studio. We have our digital laboratory. We have our photography studio. We have our two-dimensional smile design studio. We have kind of a room that we actually can engage and educate patients. What we're working on is actually design of temporary restorations, customized healing abutments on our softwares. We have added 3D printers. We've added to actually fabricate these units in the office in a very short amount of time. So now, as a surgeon, not only I can place the implant and build a foundation, but I can also create the prosthetic aspect of it when necessary to train the soft tissue and make it more of an ideal foundation for the restorative dentists to do what they need to. So this gap was always there, and for some practitioners, restorative dentists who are very familiar with prototype restorations and how to manage soft tissue was never a challenge. But the fact is that majority of the restorative dentists do not have that ability, especially in highly aesthetic cases, to be able to really manage a soft tissue based on what's required. So we're providing this service and this interaction and collaboration through our digital laboratory and design, doing some of the things that have nothing to do with surgery. It's purely restorative in nature. Customized hearing abutments, that soft tissue and the prototypes. So now we can kind of fill in that gap and hopefully deliver the patient into the hands of a restorative dentist in a better shape. So this is a very exciting project we've been working on. And really the last project, and it's kind of an ongoing thing on the horizon. I'm talking a lot about four-dimensional dentistry. You may have heard of it. I've posted everything that I post that I think meets the criteria, what I call fourth dimension. So I'm excited about this concept. I'll just finish with this in the next couple of minutes. We have the three-dimensional world under our belt. We have softwares, we have printers. We know how three-dimensionally create things. But what I've seen is that we can do all those things right and still have a patient that is not 100% happy or satisfied. Have you ever had a patient that you see after their treatment when everything is finished, they come back and you ask them, oh, you got your restoration, you got your crown. How do you like it? And they kind of look at you with a little bit of a shrug and they say, oh, it's okay. And I turn to them, I'm like, what do you mean it's okay? It's like, well, yeah, it looks good. I can eat, but you know, every time I eat, I get food stuck. It keeps, you know, accumulating and I can't keep it clean. It's kind of embarrassing. I keep playing with it. Or they say, you know, it's a little dark around the gum tissue. It's a bit off. It's not a little symmetrical. So, you know, you take a patient like this after they've spent all the time and money and effort to get this restoration and they're just okay. So I kind of like a few years ago, I kind of took a note of that. I said, you know, I don't know if okay is really good. What did we miss? What? And wow, thank you so much. I love it because that's what I like to hear. So I found out that there is a missing part between that three-dimensional world and a delightfully happy, satisfied patient. And for lack of a better term, I call it the fourth dimension. And some people thought that I was talking about, you know, being faster or easier, which is actually the exact opposite. It's slower and more methodical. Yeah. But the fourth dimension was about things that we can do to just get it right. What are the things we can do? You know, it's kind of like that little extra effort. That little extra effort, do the little bit more soft tissue graft, to do another prototype restoration, to design that papilla just the way you want to redo the provisional one more time, just to kind of change the contour and get it perfect, to get that shape and that contour just right. You know, the number of things to just close that gap and hopefully have a patient that comes back and says, thank you, I love it. It's amazing, and I want them to be in tears. So if I see somebody who's literally in front of me and telling me that, I feel like I've reached a fourth dimension. It's really hard to do, but that's kind of what my horizon is how can we achieve four-dimensional dentistry? Because it's three-dimensional. Patient-centered is not enough. What does patient-centered mean? I think we have kind of a misconception about patient-centered therapy. This is more than patient-centered. It goes into their heart and their mind, their livelihood, their time, their money that they spend, and respecting a lot of things, because we don't want to have them go back and forth and have issues and fix this and fix that. And I think that there's a lot more that we can do. It's not hard, it's not easy, but to me, the fourth dimension is sort of the goal, you know? So anyway, so that's kind of Eisen is working on these exciting projects.
Exactly, because that's the thing that we all work to reach, you know, the patient satisfaction. And when the patient is not completely satisfied, we think that we haven't done the job completely, and maybe it ends up in our disappointment in doing the treating the next patient. So that was a really great point, my friend. Hamid, I have to say it was my
Thank
pleasure
you.
to talk with you again, and hopefully very soon this pandemic ends and we see each other in person and
Let's hope.
anywhere in the world, no matter where. But really, thank you for your time. Really, thank you for sharing, for your energy. Truly an inspiration for so many of us. So, thank you again, my friend. And
Thank you.
God bless you. Thank you so much. Thumbs up.
Thank you very much. I appreciate it, Omid. All the best to you and family and health. Look forward to seeing you soon. Thank you very much.
Thank
Appreciate
you
it.
so much. Take care. Take care.
All right.
Bye bye.
Bye now. Thanks.